as was just, let me click this off. As was just said, my research focus is really specifically in the areas of sleep fatigue and cancer. So I'm actually faculty now at Penn. I was promoted, yay. So I finished my fellowship, and I will say before I get the lecture going that the study we did in my fellowship was looking at if we could use a behavioral treatment that I'm going to speak to today called cognitive behavioral therapy for insomnia, not only to treat insomnia in cancer because it works well in that regard, but also for cancer-related fatigue, because that's really the bugger, as some of you may have experienced and know. So I'm going to get the lecture started. So hold on one sec. Let me share my screen. And it came up before, but now it's not coming up. All right, can everybody see my screen?
Yes, looks good.
Let's control here. There we go. All right. So today I'm going to speak with you about having cancer doesn't mean giving up good sleep. Tips for a better tonight. So again, before I get started, we're really going to focus on some information on why we may not be sleeping, and then I'll get into some of the things that you may be able to do to help you not only sleep better, but if you're experiencing cancer-related fatigue, manage some of that fatigue. All right, so for some background. So let me see if I can move this. Okay, there we go. So let's talk about insomnia first. So how do we define insomnia, right? There's short-term insomnia, there's the more chronic and persistent form. So for this slide, we're going to talk about the chronic form. It's dissatisfaction with sleep that occurs at least 3 times per week for at least 3 months. It's trouble with falling and or staying asleep or waking up too early. And it's seen in about 39% of patients diagnosed with cancer. And one thing I will say is that number may be higher and it may be transient. And so what I see sometimes in the clinic is patients may get a diagnosis and then there is understandable anxiety about that and they have a hard time sleeping. It doesn't always mean that insomnia is going to persist. We've all, if I was standing in a room with you guys, I might have you raise your hands and ask how many of you have had a bad night's sleep, and we've all experienced it. It comes and it goes. And what we really focus on in our clinic is that persistent type of insomnia that comes and doesn't seem to alleviate. So now let's talk about cancer-related fatigue, CRF. So it's highly prevalent in cancer and in cancer survivorship, with as many as 90% of survivors being affected. Now, what's interesting about this and what we see in clinic and also in the research is that it can depend on many things, and I'll show that slide in a little bit. But what I will say is it can be diagnosis dependent. So a lot of patients who, women who have been diagnosed with breast cancer seem to have CRF. We don't always see it in prostate cancer, but it can be dependent on the person, again, dependent on the treatments, et cetera, and I'll go through that in a future slide. So cancer-related fatigue is posited to be unaffected by rest or sleep, but that's not really evidence-based. And what we've seen in some of the research that we've done in our program is that it does seem to be affected by rest or sleep. So I was alluding to this earlier when I was introducing myself, that we did this pretty neat pilot study where we used this behavioral treatment for cancer-related fatigue. And what we saw was that when we gave patients more treatment sessions, the fatigue started to go away. We're doing this study again in a larger sample, so to be determined whether we can replicate those findings, but it's pretty interesting to see that really improving sleep can improve and decrease fatigue. So when we look at some of the research in sleep and cancer, what we see is that patients have a longer sleep latency, which means that it takes them longer than the average person to fall asleep. They also have increased wake after sleep onset, meaning that these patients are awake for longer periods in the middle of the night when compared to their non-cancer counterparts. There's also lower sleep efficiency. And when I talk about sleep efficiency, what I mean is when we do these treatments like cognitive behavioral therapy for insomnia, we have individuals keep sleep diaries and we look at the averages over a week. And what we do is we calculate an efficiency. So we look at the total sleep time. So how much time you're sleeping compared, divided by how much time you're spending in bed. And that gives us a percentage. And what we like to see is patients have efficient sleep, right? That most of the time spent sleeping is in bed and you're well rested. And so that percentage would be somewhere over 85%. But what we see in patients with cancer, specifically during and after treatment, is that these sleep efficiencies drop. And sometimes, again, depending on factors like diagnosis, type of treatment, the chronic insomnia seems to persist. We also see more motor activity at night, meaning not just conscious, like getting up and walking around, but when we ask patients to wear watches, like Apple Watches, like some of you might be wearing, or Fitbits, and we monitor the activity, there's a lot more of restlessness, of what we call, you might know restless leg syndrome. At nighttime, we call that periodic limb movements. So there also seems to be some micro awakenings happening, which can really make people feel tired and not great the next day. So furthermore, when we assess patients during chemo when compared to baseline, so pre-chemo, what we see is patients are significantly less alert. They take increased and longer daytime naps. I will say, I spend my days in radiation oncology and talking to patients, and this is a big one, that lots of napping during the day. And oftentimes when we're doing the behavioral treatment, we build those naps in, which we wouldn't typically do in non-cancer populations, but it seems necessary. And I can speak to this later, but there is some thought that during specifically radiation treatment, that patients' circadian rhythms, so your internal clocks, seem to become dysregulated, and this might lead to increased sleepiness, more fatigue, and the need for daytime napping. And then again, increased wake after sleep onset, so more time spent awake in the middle of the night. And so all of this combined really leads to not feeling good during the day, not having enough energy. And it does seem to be much more prevalent during from diagnosis through survivorship. So it's something that we're really trying to address and provide more focus on from diagnosis onwards. All right, so this is something interesting that my group and other groups have been looking at. So there's some thought that insomnia, and I'm going to add fatigue here too, although this research didn't ask about fatigue, might be a prodromal symptom to cancer. So I will give you an anecdotal example here. So my aunt was diagnosed with lung cancer, but about a year before the cancer diagnosis, she just felt tired. Something wasn't right. And she kept going to the doctor and going to the doctor and saying, I'm not a napper and I feel sluggish. And eventually the diagnosis came. So it's hard to look at that in a research capacity because we can't go back in time. But what one group did is they asked patients when their sleep difficulties began, and 67% said before cancer, 33% said after cancer. And then they followed up with, did cancer cause or aggravate your sleep difficulties? With 58% saying yes and 42% saying no. Again, I'm not sure. It really does matter, again, the type of treatment, the diagnoses, but we hear this anecdotally all the time that, I'm running this study right now, and that's one of the questions I ask these women is, when would you tie the sleep problem and or the fatigue to the cancer? And a lot of them say yes. So we are seeing that symptoms can be present before, during, and after treatment. So it's something to consider. So what are some of the mechanisms? I'm going to speak to cancer-related fatigue first, and I alluded to this slide a little bit earlier. So there's many things before I even start clicking these buttons that can cause and maintain cancer-related fatigue. I often say that I picked a research topic that's like a needle in a haystack, right? And we also know that fatigue can be different. There's exercise-induced fatigue. There's a whole group of researchers that study that. There is fatigue just from, living your life. The government right now and the Air Force is studying fatigue in pilots and how do we manage that and make sure that people are safe while flying. And in cancer specifically, there's so many things. So it's trying to tease apart these things. So the first thing is physiological factors, things like pain, insomnia, of course, anemia. We have chronobiological factors. So I alluded to this earlier. So your circadian rhythm, when we think about sleep, there's two processes. We call it process S, which is sleep. This is the homeostatic drive, kind of like hunger. For most of us, as the day goes on and we get closer to nighttime, we start to get a little bit tired, and then we go to sleep and we wake up and our sleep drive is low and we hopefully have energy the next day. Then we have process C, which is your circadian rhythm. It's super interesting. All our cells have one. And again, what I said earlier was that there's some new research coming out to show that in radiation treatment specifically, there might be a dysregulation of this circadian rhythm leading to problems like differing needs for bedtime. So maybe going to bed earlier and wanting to get up earlier, or insomnia and things like that. So we're losing a stable sleep-wake pattern. Then we have physiological factors. So just the stress of getting a diagnosis, of going through treatment, and all of that can lead to depression and anxiety, which definitely can increase fatigue. We have cancer type and stage. I've said this a bunch. So in the patients I see who may have a breast cancer diagnosis, they seem to be more fatigued than other diagnoses I see. And then stage, of course. The iatrogenic effects of treatment, meaning again, having surgery, different doses of radiation, chemotherapy, all of these things can lead to increased cancer-related fatigue. And then we have sociocultural factors. So one thing that they've been doing research on is how providers prefer for tests and when patients end up getting diagnosed, and then treatment. And what we see in some research coming out of the Medical University of South Carolina is that Black women often don't get diagnosed as soon as their white counterparts, and this can lead to higher stage cancer, later stage treatment, which again can decrease survivorship, but also increase some of these symptoms like cancer-related fatigue. So what are some tips now? I know you guys have been waiting. I've given you the background now, but what can you guys do for better sleep? All right, so let's talk a little bit about sleep architecture. We've all heard, right, many of us, about REM sleep and about the different stages of sleep and how much sleep we should get. And there's lots of stuff on the internet, and you hear it on TV, take melatonin, don't take melatonin, take this medicine, don't take this medicine. What we do know is that we have, depending on what you're reading, they've now combined stages 3 and 4, but for our purposes, we'll talk about 3 and 4. We have stage 1 sleep, which I call dad sleep because of my own father. He often falls asleep in a chair. When we go to wake him up, he says I wasn't sleeping, which means that this is a very light stage of sleep. It's the first stage. It almost looks like wakefulness. Then we have stage 2. Stage 2 is really interesting. There's lots of people trying to figure it out. You can you note it when you're looking at a sleep study when patients are hooked up to EEG, because it has these things called K complexes and sleep spindles. We think it has something to do with preparing you for either stage deep sleep, stage 3 and 4, or REM sleep, but it's super interesting. We spend a lot of time in stage 2. Then we have stage 3 and we have stage 4. This is deep sleep. This is the sleep you need to feel good the next day. What happens in insomnia specifically is that patients kind of surf through stage 1 and 2. They wake up and come out of it, and they don't really get stage 3 and 4, that deep sleep. The other thing that happens that's interesting as we age is we start to lose that deep sleep. And there's some scientists over in California that are trying to replicate this sleep to help older folks get this deeper sleep. And so it's super important. And it's also why it's important to manage the insomnia so you get that deep sleep. Then we have REM sleep, our rapid eye movement. It's super interesting when you look at it on an MRI scan, the whole brain is lighting up. And we spend about 20% of our time here. We dream here. This is where you have your vivid, weird dreams, or maybe you're having, tea with an elephant or something. This is our REM sleep. And it's also super important. What happens though when you're sleep deprived is you often drop right into REM, and that's not good either. So again, I really want to drive home that we want to cycle through these stages in a systematic way and get the deep sleep. A sleep cycle is about 90 minutes. I will note here when we talk about waking up early in the morning, so if you wake up earlier than you want to wake up, it's probably important that you just get out of bed. And part of this is because if you doze off, again, you're going to cycle through stage 1 and 2, and you're not going to go through a full sleep cycle, which means you wake up and you feel kind of groggy and icky in the morning. So I had somebody ask me in a recent lecture that I did, what about when I hit the alarm and then I hit it again? My advice for everyone is just if you're going to set an alarm and you're going to hit it 5 times before you get up, just set it for that later time and get right out of bed. Don't cycle through the kind of early stages of sleep. And this picture here, just for some education, is called a hypnogram. And this is what you see if you have ever been to a sleep study and they gave you a report and they gave you the full report, not just the doctor write-up, you might see a hypnogram. And what you see is the top bar here where my arrow is awake. This person dips into deep sleep. They come out into REM. And then these little bars here are awakening. So they're having a few awakenings in the middle of the night, about 4 hours into the night. Another thing to know about REM is REM gets longer in the latter half of the night. So for a good sleeper, this is what you should see is longer REM periods as the night progresses. All right, so how much sleep does one need? This is a question I get the most when I'm doing cognitive behavioral therapy for insomnia. The focus is really on, but I need more sleep. And the transition I try to make with my patients in the thought process is actually, let's focus on quality sleep, right? Because most of us are getting about 6 to 7 hours, but it might be fragmented. And so what I try to do with patients is consolidate that sleep and get them a really nice chunk. So it's not always about getting more, although if, for most of us, again, we need about 6 to 7-ish as we get older. But really focusing on the quality, not the quantity. And I think in the zeitgeist, it's really about the quality, the quantity. I need 8 hours of sleep, but that's not entirely true. A little interesting factoid is about 100 years ago, people were sleeping about 9 hours. I think that's probably changed due to technology, screens, our schedules. And also they used to sleep in 2 bouts. So people would sleep and then kind of like they do in countries like Spain, you might take a siesta, get up, have dinner, or get up, do some more work, have dinner, and then go to bed a little bit later. But that has certainly changed over the past century. All right, so let's talk about sleep need. So sleep need is exactly what it sounds like. How much do we need to feel good the next day? And then we have sleepability. How much can we actually sleep? So one of my mentors always says when he's doing these lectures is the old phrase is sleep like a baby. And if I was sitting in front of you, I would say, how many of you have been around a baby? And people will say, yeah, you definitely don't want to sleep like one, right? They're up every couple of hours, they're crying. Who you really should aim to sleep like is an adolescent. If any of us have been around an adolescent, I remember being one, they need about 10 to 12 hours. They sleep like a rock. And they get really good quality sleep if allowed to do so. For those of us in middle and older age, again, we need about 6 to 7 hours, and that's usually our ability. That's what I see in my patients. However, what happens is life gets us, life stressors happen like a cancer diagnosis, and we become a bit sleep deprived, and our sleep need is fairly high, and we're tired during the day. Then we have sleep opportunity, which is how many hours are we giving ourselves per night to sleep, right? So again, 6 to 7 hours is what we should be giving ourselves, and we should be spending most of the time in the bed sleeping, not necessarily awake on our phones, tossing and turning. So we like these things to align, our sleep need, our sleep ability, our sleep opportunity, but that doesn't always happen, right? And how insomnia begins to form and become chronic and persistent is we're spending more time in bed awake than we are sleeping. And so there's a slide coming up where we talk about what you should be doing in the bedroom. But these are the things that we really want to have aligned. So if you look to the left, we have efficient sleep, right? I spoke to sleep efficiency, where this Venn diagram, sleep ability, sleep opportunity, and sleep need are aligned. What you see on the right here is that sleep ability is smaller. We have sleep need, which is expanding, and then we're expanding our sleep opportunity. So we're trying to sleep. We're engaging in what we call sleep effort. If you ask a good sleeper what they do to sleep, they will say, look at you quizzically and say nothing. I put my head on the pillow and I go to bed. With insomnia, though, it makes sense that we're doing what our body is telling us to do, our brains are telling us to do. Try to go to sleep. You need to go to sleep. There's often concerns and anxieties about what tomorrow will look like. What I encourage people to do is disengage from the sleep effort, get out of bed if you can't sleep. And as soon as that thought process clicks in and you're tossing and turning, get out of bed if you can, go to another room and watch a TV show, watch an episode of Friends, 30 minutes, and then go back to the bedroom and try again. All right, so what do we do? So I'm going to just pivot really quickly and talk a little bit about cancer-related fatigue and talk about the treatments for that, because there aren't many. We don't have a lot of great treatments for it at this point because we haven't pinpointed what the mechanism is. However, there's a lot of research. Multiple sclerosis researchers have really dug into this, and they're doing a lot of really great research in this arena for fatigue. And what they have found is exercise is a really good option if you can do it. And I don't mean you don't necessarily have to run on a treadmill like this little figure here, but even going out and taking a walk, walking to the mailbox, that can be super helpful. And what the D means is that's an effect size. And so an effect size of 0.3 really is, it's okay, it's moderate, but it does seem to work. We also have medication. You can see here, this is a very small effect size. So medications like modafinil are sometimes used for cancer-related fatigue. They don't work super well, but they do seem to take some of the edge off. And then we have CBTI, cognitive behavioral therapy for insomnia. The effect size is pretty good, 0.46. One is like really good, 0.46 is almost right in the middle. And so we've seen this in some of the work we're doing now that we hope to publish soon, that it seems, especially as a higher dose meeting number of sessions, to work well. One thing that isn't on here that I need to put on here is light. So one of my mentors, Dr. Nkoli Israel, chided me for this. She was like, where's the light? And I need to add this. So let me just say that light is super helpful. So exercise combined with natural light, like sunlight, if you can, especially, I know it's really hot right now, but if you can on a nice day where it's a little bit cooler, taking a walk and getting sunlight can be super helpful for fatigue if you can manage it. All right, so I'm not sure where everybody is located on this call, but I've spoken a lot about cognitive behavioral therapy for insomnia, not just for insomnia, but it also can be helpful for fatigue as well. Is a behavioral treatment for insomnia currently considered first line. It's 6 to 8 sessions. Sessions are anywhere between 30 to 45 minutes each. Many providers do this treatment virtually. It uses behavioral, cognitive, and psychoeducational interventions. And I just said this, it's a first-line treatment endorsed by the American Academy of Sleep Medicine and the American College of Physicians. It's super effective. The reason why I said earlier, a minute ago, that whereas everybody is, there is a paucity of providers. We have a lot of providers on the East Coast. If you're in New York, if you're in New Jersey, if you're in Philly, if you're in California, but in the middle, there's not many. But if you're interested, please email me and I can certainly help you. We have a provider directory and we can locate someone. But it's super quick. The sessions get, they're towards the end of treatment, it's about 15 minutes, it becomes a check-in. So super effective treatment. It's how I got into this. I couldn't believe how well it worked. I just want to sell it here because if you're having trouble sleeping, you don't have to. And the beautiful thing about CBTI is that when you're done, you have a skill set. So when you're taking sleep medications, you stop taking the sleep med, right? And the insomnia comes back. But with CBTI, you know what to do if you start having insomnia again, which is a beautiful thing and quite empowering. All right, so let me quickly go over the nature of insomnia over time. So we talked about acute insomnia, which is the short-term version, which is in response to a stressor. We have this early phase, which is kind of, we call poor persistent sleep. It's not quite chronic, it's not quite short-term, but it's in the middle. Most people will go back to their pre-morbid phase, which is no insomnia. And then we have chronic insomnia. What you see on these different colored bars here is we have these predisposing factors, maybe genetics. We have the precipitating event, and then we have the perpetuating maintaining factors, which is really spending time in the bedroom awake, not having a stable bed and wake time. And those things can really cause insomnia to take on a life of its own. And then this is just, we really think about Pavlov's dogs. If you don't remember, Pavlov talked about conditioning and how we learn, and he used his dog. And so he paired a tuning fork with food, and over time, the food wasn't necessary to elicit the salivation, right? It was the tuning fork. And this is what happens in insomnia, is that the bedroom and the bed become the stimulus for wakefulness. I call it party time. So many times my patients will say, I can fall asleep on the couch, but man, when I walk into the bedroom, I'm wide awake, and I call that party time. It means your brain has been conditioned to respond to the bedroom as a place for wakefulness and not for sleep. So part of what we do in treatment, and part of what I encourage you to do if you're having insomnia, is break that relationship. And you do that by not spending time in the bed in the bedroom awake, and just making the bedroom a place for sleep, a cool room, a dark room, no screens, none of that. That can all be done in a different room if possible. All right, so what is good stimulus control? How do we make the bedroom a place, a stimulus for sleep? So good stimulus control, sleep, sex, that's what you do in the bedroom, nothing else. You have odds 1 and 2 that you're going to fall asleep. Stimulus discontrol is eating in bed, reading in bed, watching TV in bed, working in bed, worrying in bed, cleaning the bedroom, all of that stuff that leads to chronic insomnia. So odds 1 in 8 that you will fall asleep. And that's all I have for you today. If you have any questions, I'm happy to answer them now. You can also, I'll leave this up for a minute so you can write down my contact information. I will say we are recruiting for the study I spoke about earlier, where we're looking to test cognitive behavioral therapy for insomnia, to treat insomnia and cancer and fatigue. So if you have any questions or interested in that study, please feel free to email me. You can also email me for, if you have questions about treatment providers in your area. We do provide virtual treatment at Penn. So we have a bit of a wait list right now, but we're also available. So feel free to contact me, and thank you.